Hi, good afternoon. Thank you for your patience as we got started. Before we introduce today's speakers, I just want to make a couple of brief announcements. We know that many of you are listening in from far away and can't attend local events or programs, and that's why we provide this free webinar series. We do host multiple webinars each month, so please visit our website to view the current schedule for the rest of the year. Our website is johnson-center.org, and you can click on the webinars link on the right-hand side. There are new webinars and events that are often added, so if you're not on our email list, I do encourage you to visit our website and click on the Join Our Email List link that appears on the homepage. We do still have some great summer events coming up, including some free family fun, so check it out. To get instant news and events from the Johnson Center, you can follow us on Facebook, Instagram, and Twitter, as we do often announce grant and scholarship opportunities, research opportunities, and last-minute events and presentations there. And be sure to check out our YouTube channel at youtube.com/thejohnsonCenter. There you'll find a library of several of our past webinars covering a wide variety of topics. For those of you who are local, be sure to check out our Junior Series event this Saturday, the Junior Heroes, a free, fun family event for all children ages 4 to 10. You can find more information on our Facebook and Instagram pages and on our website. Be sure to follow our colleagues at the Autism Research Institute as they host their own webinar initiative, and they share some great resources on their website and social media pages. Now, if you'd like a certificate of attendance after today's webinar, watch for a follow-up email in your mailbox 1 hour after the webinar concludes. It will contain instructions on how to get your certificate. I want to welcome today's speakers, Kelly Barnhill and Amanda Tami. Kelly is the clinical director here at the Johnson Center, where she's active in providing clinical care as well as a critical member of our research team. Amanda is a licensed professional counselor and a board-certified behavior analyst, and she oversees the counseling and behavior programs here at the Johnson Center. To submit your questions on feeding today to either Kelly or Amanda, you may type your question into your GoToWebinar control panel throughout the presentation, or you can send them via email to info@johnson-center.org. Again, that's info@johnson-center.org. So I want to welcome Amanda and Kelly and get your questions submitted.
Hi, good afternoon. This is Kelly. I'll get started with a question that we got many copies of when people were sending in questions in advance of this time together. And it's a pretty common nutrition question that we see in clinical practice as well. And essentially it boils down to, what do I do to get my child to eat more vegetables? So from a nutrition perspective, we often see children who come in for clinical analysis and won't eat any vegetables whatsoever. And to approach that from a dietary standpoint, we use a number of different tools and tricks. And the basics for us are, number one, know that your child needs those minerals and vitamins that they would be getting from those dietary components. So if your child is not eating any vegetables, either for sure be using a vitamin, or think about supporting with a phytonutrient, vegetable-derived, fruit-derived powder as well, and consider it just a baby step toward your ultimate goal of them accepting vegetables and fruits in their diet. But there are a number of good products out there, and think about it as short-term as you problem solve this issue. Beyond that, if you want to start introducing things in food, another kind of bridge approach is the sneaky way, and there are a couple of books out there that you might want to look at. One called The Sneaky Chef and one called Deceptively Delicious, and there are two of those out now that help you hide successfully, and we use this strategy frequently, vegetables, pureed vegetables and fruits in other foods so that children can't find them. And then finally, and we'll talk about this more later, I'm sure, with other questions as they come in, but from a behavioral perspective, know that you have to introduce food over and over again. And the research tells us, upwards of 15 times the food needs to be presented before a child will actually consider trying it and maybe liking it. So be persistent and consistent. So.
My turn? All right, and I have a question also sent in prior to the webinar, how can parents begin to implement some of this at home, meaning behavior therapy for feeding or for eating, if they can't afford to pay for feeding therapy, for behavioral feeding therapy? And that's another question that we get quite often. First, if you're considering taking a behavioral approach to feeding, before you start, make sure that there are no underlying medical conditions that are in place that are making feeding difficult. For example, any challenges with swallowing or chewing or gastrointestinal issues that can make eating or digesting food painful. We want to address those first, because any behavioral therapy that we put in place is going to be less effective if the mechanisms of eating are not effective. So if you find that there are no medical conditions in place that need to be considered first, and you are ready to go ahead and get started, we're using the same principles of operant conditioning that we would use with any ABA, the reinforcement of wanted behaviors, withholding of reinforcement for unwanted behavior, having instructional control, saving the most reinforcing items for this, for feeding. And, excuse me, you start there. Start just by reinforcing the behaviors that you want. And we do this using shaping, which you may be familiar with if you're already using ABA, where we start with something very small that is not the end behavior that we're looking for, but we start with something very small and gradually work up to that behavior that we want. So it might be that we start with just being near the food. If food is so aversive that a child won't come into the kitchen or won't sit at the kitchen table when there's food there, start just with that and reinforce it. Lots of those most preferred items, lots of those favorite activities, make it fun, singing, watching videos, just for sitting at that table. Then gradually increase the requirement to something more, like maybe now they have to smell the food. Maybe now they have to kiss it or lick it. And again, lots of reinforcement for all of those. For each of these steps, we're reinforcing. And then gradually they have to take a bite. Maybe they take a bite and spit it out. Gradually work up to taking a bite and swallowing it, taking multiple bites, or taking bites and of a variety of foods. So we're shaping the behavior from just being near the food up to eating the food that we want in the way that we want and reinforcing it each step along the way. And the more opportunities that you give your child to do this, to get that reinforcement, the more opportunities they have to practice and the more successful they will become, the more proficient they will become at eating. So use these interventions as much as possible. If you can, with 3 meals a day, every meal they're sitting at the table and you're using that shaping and lots of reinforcement to increase that, whatever level of that shaping you're on right now. Give as many opportunities as you possibly can. And finally, earn trust by following through with the demand that you set and with reinforcing. If they know that they are being reinforced for this behavior, then they're more likely to do it. So follow through with all of that reinforcement. And also in terms of trust, tell your child what you're doing and what's expected of them. Don't lie about what they're eating or try to trick them into eating something because you know that they'll eat a cookie, so if you tell them that this blackberry is a kind of cookie, they'll eat it. We want to be honest and tell them exactly what it is that they're eating so that they know that they can trust you in this context of eating, and what you say they're having is what they're having, and that's going to be okay. And mistrust in the context of eating can actually make feeding issues worse. So honesty and telling them exactly what they're getting without trying to trick them into eating it is the way to go.
To follow up on my earlier question, we just got one on if the only vegetable my child eats is French fries, what foods can I try and what do I do? Again, we see that often, and really from a nutrition perspective and also a behavioral strategy perspective, what we do, or what I do in practice really, is recommending and modeling something called food chaining for families. So, for example, if we have a child come in and they will only eat a specific type of fast food French fries in that container, we start there. And then we can start by introducing another type of French fry. And when that child accepts that, then we start with, okay, how do we get more creative and get more nutrition in there? Let's look at sweet potato fries, for example, or butternut squash fries. Let's prepare them a different way now. Let's bake them, not fry them. Let's change the shape. Let's expand. Once they've accepted a different taste, let's start working on a different strategy and bring other nutrients in, because a white potato is fine, but a sweet potato, butternut squash, other things that we can make look similar but have greater nutritional value are my goal when we start something like this. Another question that's come in, and we had several before our webinar started as well, is a variety of how do I get my team to work together on this process? So what do I do to have my BCBA or my OT talk to my nutritionist or dietitian who I'm working with? And as the parent, unless you're in a multidisciplinary program and working with those professionals who are under the same roof or have a colleague and collaborative relationship, really the burden really is on you to communicate clearly with those professionals about what you want. And we counsel families to be an open line of communication for both professionals. Often it is hard or difficult to communicate if a family wants to try a particular dietary intervention, for example. It's hard to communicate that successfully, or families often carry some guilt or unease in asking for a dairy-free diet or a candy-free diet, and really, if you open that door and you're honest with that professional and say, look, we have invested a lot of time, effort, money, resources in working with a dietitian who's worked up a plan for us that we would like to implement, and we respectfully request that you help us by following these guidelines. More often than not, as long as the parent is earnest in presenting that, you can offer to set up a conference call, you can offer to provide reports on what's needed, and that seems to be, bridging those disciplines seems to be much more common now than it was even 2 or 3 years ago. But being that, I guess, the bridge is just another role that parents get to play right now in many circumstances. So.
Okay, next question for me, for Amanda. Should I use an OT or a BCBA for a feeding therapy program? And this is a good question, and an occupational therapist and a BCBA are going to approach feeding differently. Your occupational therapist or a speech therapist is going to look at any oral motor problems or physical difficulty for your child and address those. And they're also going to work a lot on the sensory aspects of eating, gradually changing the flavors of food or introducing new flavors, new textures. They give kids food to play with to get used to the food, the different textures, and that food is, kids learn that food is fun and not something to be scared of. Whereas in behavior therapy, the BCBA is going to use the principles of reinforcement and learning that that eating is what is going to earn them reinforcement, and that this is the expectation that we're going to meet. And while acknowledging that foods can be scary, using this systemic systematic desensitization paired with reinforcement to decrease any fear associated with it. So which approach you take, or whether you go to the BCBA or to the OT, really depends on your child's needs. If there are real true sensory issues, or if there are any oral motor issues, then the OT is the person to go to. A lot of people will turn to behavior therapy for feeding help because occupational therapy has not been effective in helping to address the feeding issues. And as a follow-up question, I was asked, do you think that sensory-based feeding approach alone without behavioral interventions makes enough of an impact in children with ASD? And the answer to that, as often the case, is it depends. For some kids, that really is all they need, and if they have that exposure through the OT, or if they can get that oral motor help that they might need, that can make a really big difference. For other kids, behavioral intervention is much more effective in the long term, and is really what is the intervention that is much more effective in producing the results that we're looking for. But it's really dependent on the specific child and the needs that they have.
A couple of other questions have come in for us. The first is, do you have any knowledge or experience with using essential oils in cooking or baking to help with symptoms and to help the child want or like more foods? Yes, I have experience with essential oils. It's something that has become more and more common, both questions that parents ask when they come in and things that we track and manage in clinical care. But it's not something that I feel well versed enough in talking about utilizing it to increase appetite, for example, or to promote acceptance of foods that I can really speak knowledgeably to here. I feel like some of that information is available from a few of the high quality oil distributors that are out there, and you can find some of it online, but I believe there are also webinars and local workshops that address that issue as well, that would give you some background information to be able to do that well. Another question that came in is, should I let my child graze in terms of eating, or should I establish set meal times? And I think, as Amanda mentioned earlier, it really does depend on a number of factors. And that's something that we talk families through on a case-by-case basis. So how old is the child? What's the child's nutritional and growth status? What are the family dynamics? How did you get to this place where grazing is their primary source of dietary intake and participating at a table is not? Looking at toddlers who are under 2 years of age, I mean, we know the research tells us they're processing and trying so much new stuff all day long, every day, that our expectation that they're going to sit still for us at a meal time is a little bit unrealistic, because they're still figuring out through experience really what that's all about. As you look at older kids, I think grazing can be appropriate in some instances, but it's also important to think about what your goal is. So if our goal is to increase dietary intake and broaden the nutritional status, then I think withholding snacks to graze on throughout the day so that you get better information and more accurate information about what they're actually eating and what's going in is appropriate. If you have a child who eats well and simply just doesn't prefer some foods, but they sit at a meal and enjoy a meal, and then they also graze at times, I think that's entirely appropriate, because you're not talking about a child who is resistant to food intake necessarily. You're just talking about a child with preferences or a picky eater. So.
That's for you.
Okay.
Okay, next question. What if your child has a sensory issue with food that makes them gag and throw up? And how can behavior therapy help with this? So my first question would be, are we sure that it's a sensory issue? If the child, for example, has gagged in the past and then has gotten out of eating that food, could that gagging be escape maintained, or did they get a lot of attention for it and so it's become attention maintained, or even did they gag and then because they gagged with that food they got to eat a food that they prefer to eat? My first question is to make it, are we sure that it's sensory? Let's make sure that this truly is, that the gagging is truly a sensory, the reflex, and it's not somehow learned from, could be a very long history. It could have been from very long ago that they learned that gagging got them some other, it served up some function for them. So let's make sure that we have the function right before we look at, before we assume that it is a sensory issue and that the gagging is strictly because of the texture of the food or because of the way the food smells. Let's make sure of that first. When gagging does happen, don't make a big deal about it. It's pretty natural for all of us to gag at some point, and instead just respond by saying something like, oh, that's okay, it must have gone too far back, or that's okay, let's try another bite, and have them try another bite of that food. And that fear that they might have from gagging, or especially from your response to their gagging, can amplify the fear that they then have in the future that they will gag again. If it really is related to texture, Kelly might have some suggestions for that, but using this systematic desensitization or shaping, where we start with just looking at and licking and smelling the food before we're actually requiring them to put it in their mouth and then swallow it, taking those smaller steps first can help to decrease the gag reflex and can help to decrease the, not only the fear but also the physical reaction that they might have because of the texture issue or whatever it is about the food that causes the gagging.
Another question that's come in right now, how can we as parents help educate our school and the teachers about our feeding limitations, our requests, our D recommendations, etc.? Either our children get left out of the treat, such as a treat, a snack, a drink, etc., because they can't have it, or the teachers completely ignore it and offer it to them anyway. We would love for our schools to stop rewarding with treats, but that doesn't seem to be of any interest to any of them. Thank you. Okay, know that you're not alone in this, because every family that we work with navigates this in some way. And the strategies that we use and recommend, we have a long list of things that we suggest for families to be successful in this. And I particularly believe that the most important thing to do is build a personal relationship with everyone in that building. And if this is a new school, it sounds like you're in the same school going in this fall, but go in and foster solid relationships with every person there who's going to interact with your child. So go back to the teacher that you know already, or go to the new teacher, go to the teacher's assistant, go to the cafeteria line workers who are interacting with your child. Go to the monitors in the lunchroom, go to the administration, provide them with as much information as you can. And based on what you've said here, I feel like you've offered all of that. So the next thing that we suggest really doing is building the plan A, plan B, plan C in these circumstances for families. So perfect case scenario, for example, you're in a preschool, and the school has parents provide snacks on a rotating basis. So week 1, this family does, week 2, the next family does. Ideally, through building that rapport and communication with the school, you get to a place where the classroom teacher and the administrator agree that, okay, we should tell parents to choose from a long list of snacks that everyone in the room can eat from. So build your list. If your child is eliminating certain things on their dietary approach, keep those things off the list, but build a list of 200 items and be as explicit in that as possible. So roasted pecans, raw pecans, whatever it is that accommodates everyone. So that give brand names of things that are specialized so that you can put that in the hand of the teacher and the administrator and say, my child can eat anything on this list. Is there any way that we can combine this list with the list that I know other families must have so that everyone in the room can have the same snack? That sometimes helps because it appeals to the idea that we really want to be inclusive, not exclusive. And our kids fight enough battles, in my opinion, that building trust and being inclusive in their environment doesn't have to be hard. And if we give people who don't know how hard it is or what to do really, even if they do have good intentions, give them that list and help them do that. So that would be plan A for me, perfect case scenario. Second thing that we suggest families do is bring the box. So the treat box goes in the classroom cupboard, and when those things come up where families, oh, they're left out of a treat, oh, there's no drink, well, guess what? There's 100% pomegranate grape juice mix that's organic in the closet that you can pull out. And while it differentiates them, it doesn't allow them to participate in the community experience, it doesn't exclude them completely. Same thing for the other issues. So there's a treat of some kind salvaged in the freezer, in the teacher's lounge, and in the cupboard if necessary. So in a pinch, if there hasn't been good communication, they are still included. Another option is, please notify me of any birthday celebrations or other classroom celebrations that may or may not come up, so that I can bring something fresh for my child. I can either prepare cupcakes, or I can do something else that my child would also be able to be included in this activity. And set a reminder on your phone and in your email so that you know, okay, I need to send out my Thursday email. Hey, could you tell me if there are any celebrations next week that I need to be aware of? And that seems to work well for families as well. I think that the more we can do to provide information and let schools and other families understand how critical this is. Yes, my child may not have a crucial, life-threatening allergy that requires an EpiPen. That's why you don't see an EpiPen here in his classroom, but he does have significant food responsiveness, and we need to take it just as seriously. We can begin to kind of change the way they look at it. And in doing this for so long now, we have seen more open-mindedness, I guess, in understanding that people need to follow different dietary protocols for various reasons. The final thing that I suggest to families is have the administrator and the teacher talk to your practitioner, or ask if they would do an in-service for the parents and the school before school starts or in the fall term, so they can understand just the big picture questions, because if this affects your family, I'm sure it affects many other families in that school in different ways as well. And if you go to your provider, if that provider is someone that you trust, and say, hey, would you be willing and interested to do an in-service presentation for the faculty, yes or no, would you be willing to do a 1-hour talk with Q&A for families at my school so they can understand about food? The chances are that provider will at least offer you resources if they're not available to do that. So hitting it on every front, I think, is really important. If you're in a school program, whether it's public or private, that acknowledges an individualized education plan or has a learning strategy for kids who receive additional support, I strongly encourage you to put recommendations for food intake and food environment in that plan so that it's documented at that level that your child has some particular dietary intake needs that need to be acknowledged and followed.
Someone responded to you. How long should a feeding program last? Again, this is going to be an individualized answer depending on the child and their needs and what kind of therapy they're getting. If they are working with a therapist once a week and that's how often they're exposed to this intervention, then it's going to take quite a bit longer. If it's something that you're doing with your child at every single meal, it can happen pretty quickly. We do an intensive feeding program that would last about 5 days, can be a little bit longer, could be a little bit less, and we would provide behavioral therapy at every meal for 5 days, including at home, at restaurants, in different settings to help for generalization, and 5 days is about the average time that takes. For some kids, especially those who are very young, it might be 3 or 4 days. For kids who have a much longer history of reinforcement and a much longer history of this behavior, it might take more than that. But how long a feeding program will last is going to depend on how often the child is exposed to the intervention, how much practice they're getting, and how much reinforcement and how much of the demand is maintained. So it really, I don't have a concrete answer to that question. How long should I or should I withhold preferred foods? So if you're doing a feeding therapy, the best thing to do is to not allow feeding in between meals. At meal times, this is when we eat. They have the opportunity to eat, and if they don't eat at that time, then the next opportunity to eat is at the next meal. And by this deprivation, they become hungrier, they become more motivated to eat, and so withholding foods between meals is a good idea while you're doing this feeding intervention. Now, once that feeding intervention is complete, you finish the therapy, and the child is eating as you want them to be eating, then going back to grazing might be okay. But during the intervention, you're controlling when they have access to foods in general. And as far as preferred foods, it's great to use those as reinforcement during meal times, that if they have a bite of this non-preferred food, then they get a bite of the preferred food, the food that they want to eat. And that's a really easy type of reinforcement that you can incorporate into the meal time. Getting more? Okay.
One of the questions that we've gotten is, we've been struggling for years with my 8-year-old's eating pattern. What do you suggest if he is tired of his safe foods and barely eats them anymore? So in our clinic, the first thing we would really do from a comprehensive perspective is get more data on what he's eating, what the nutritional content of that is, and that gives us an idea of, and also his preferences, so what those look like. And once we do a nutritional analysis and we see what deficits are there, then that gives us better data to decide what the next plan would be. And I feel like more often than not, when a family tells us this has been an ongoing issue and he is in 4th grade now and he will eat 3 foods and he will only eat 2 of them sometimes, this is the time when, from a clinical perspective, we say, okay, let's make sure that we've ruled out any medical involvement. So we've ruled out any diagnosis that might preclude the child from enjoying any food, and that can be fairly comprehensive in some instances, and it can be fairly easy in others. It just really depends on the child's presentation and their particular circumstances. But once we do that and we see, okay, we have this data, we have a child who doesn't enjoy this process that should be enjoyable community experience, and we look at the stress that it places on the family, we understand the stress that it places on the child, then we talk to the family about, okay, what do we do next? Do you want to do a feeding intervention plan like Amanda mentioned? Because if a family wants to commit to that, we would then develop a feeding plan. So we would design food targets for families specifically to use during that 5-day process that Amanda mentioned. And then that behavioral program would take place. Sometimes families say, well, I really want to keep kind of trying at it, and then we say, okay, let's make sure at minimum that his nutritional needs are met. So we need to add these vitamins, we need to look at adding fiber, for example. But more often than not, if we choose that approach, families will come back within a matter of months and say, okay, we're ready. We understand now what you said, we've lived with this stress a little bit longer, and we're ready to begin an intervention plan.
Do we train parents before approaching the child? What if both parents resist or justify the rejection of the food? Well, if you are a professional working with kids and doing feeding therapy, we at the Johnson Center, when we do feeding therapy, we require a parent to be present when we do the therapy. The parent is going to be the one who is at home with the child and having mealtime with the child. So the parent needs to be able to implement the intervention when the behavior analyst or the behavior therapist is no longer there. So my recommendation would be that if you are a professional doing behavioral feeding therapy with a child, it's a great idea to do it while the parent is present so that they're learning from you and you can teach them as you're doing it how to implement the same thing at home. If a parent or caregiver resists it or justifies the food resistance, then I guess that depends on whether or not they have sought you out for feeding therapy or if it's a recommendation that you are making. And as is the case for resistance for most anything, explore with the parents where that resistance comes from, why they believe that, how they decided that, whatever the child is, that food refusal is justified, or that they think that this intervention is not going to work. That's okay. These things happen, and remind them that they are that we can make adjustments as we go along, and that if they're not on board, the intervention is going to be much less effective. That if they are not willing to commit to doing this at home, then likely whatever you're doing during therapy is not going to be effective. So make sure that they understand that, and if it's not something that they're interested in or not something that they want to proceed with, then it may not be the right intervention for the family at this time.
What are the important things to think about from a diet perspective when we're adding new foods? So how do we identify what we start with is one question we've seen a couple of times. And from a nutrition perspective, there's this prioritization of things that we choose. And it really comes down to the data we gather from that child on an individual basis. So looking at your child, are they consuming foods across the food groups? So are you getting in something from some type of protein, some type of carbohydrates, some type of fats every day on a daily basis? Are they eating fruits and vegetables? And kind of do an inventory there. Think about and look at broadening any particular foods that are based on, you know, he will only eat broccoli. Well, okay, do we need to target, once we know that all those macronutrients, that we know that they're getting enough energy from their food and they're coming across food groups, then you can start differentiating inside a food group. And introducing foods that are similar to foods that are preferred now, so that they might, or prepare it in a way that foods are served now so that they might be accepted. If you notice if we notice nutrient deficits, so we do a dietary analysis, we look at current food intake, and we realize, okay, this child isn't getting any calcium in his diet right now. We need to target foods and also add supplementation in a way to meet his required calcium needs. We realize a child isn't getting any essential fatty acids. How do we do that safely for that child, and what does that look like? And we go through and target foods based on broadening the scope of what they're eating as well as hitting nutrient requirements.
What do you do when ABA fails? Well, as is always the case, if ABA is not working, then we need to change something. In ABA, if we're not seeing progress as we expect to, if the behavior is not, the behavior that we're teaching is not increasing, if the unwanted behavior is not decreasing, then we need to make a change in that intervention. So for feeding, that might be things like we need to find stronger reinforcers, or we need to take a step back and step back earlier into that shaping procedure, and maybe we're not ready to go up to taking and swallowing a bite yet. There's a lot of possibilities, a lot of things that we can look to change. And depending on the child, we'll find something to change. That can be something as small as this food is just not going to be the one that my child is going to have. We need to try a different food. And let me add, I had talked earlier about gagging, and that, you know, make sure that it's really is a sensory thing. But regardless, if gagging is happening, everyone has a certain amount of foods that they just do not like. No one likes everything, and it's normal to have a few foods that you don't like and you're not going to eat. And maybe that, I don't know, that blackberry is something that your child is just not going to like, and that's okay. That is just, it's still a good idea to try it and see if that gagging is behavioral rather than a physical problem. And in that case, if we find that we just cannot get past the gag, then that might be one of the foods that they just do not like and are not going to be eating.
So we have a few more minutes left here. If you have any outstanding questions, please be sure to send them in now so that we have a chance to address them in the coming moments. Otherwise, you're welcome to email them, and we can try to get back to you via email with any particulars. I have one general kind of question that came in. How do we know if our child has an eating problem? And what does that look like? And so really the basics are ultimately, I talk to families a lot about picky eating, because as adults, we're allowed to like foods and not like foods. We are allowed to have preferences and things that we prefer to choose on a menu, or we prefer to make at home for ourselves. And children are called picky, and there's a negative connotation when they express their desires. So I really try to help families think through, it's okay if a child doesn't like a blackberry and never will, for example. And where do we draw the line between where it becomes a problem, both for physical health and also behavior? And the general guidelines, there's a variety of research out there that looks at foods, and in most instances families will tell us, oh, my child really has an eating problem, and I need strategies for increasing the child's feeding. And when we do the analysis, we realize the child fits into, they'll eat 20 to 25 foods, mostly across a variety of food groups. There aren't any huge deficits, but we want to expand the diet from there. And so we can build strategies that families will try at home with specific food recommendations and behavioral approaches that can allow families to be successful, to broaden the scope of what the child eats and increase their nutrient content. When it becomes tricky is when you talk about resistant eaters or problem eaters, and those are kids who are consuming maybe 6 to 8 or fewer foods. Those are kids who are refusing and continuing to limit their dietary intake, even from preferred foods over time, like the mom mentioned earlier. Those are families and kids who have complete food groups that they won't consume. So no protein goes in of any kind. No, they're not getting any fruits or vegetables in their body. They don't have one preferred food. Kids who will limit to one texture only with then limits of what type of food or what type of energy is coming from that food within that. And those are the families that we suggest to find evaluation locally with a provider who can help and assume some of the responsibility for solving that problem and increasing dietary intake as well. So a medical evaluation, a speech, OT, behavioral approach, and evaluation to look at increasing dietary intake, because that's when you self-limit to the place where you're excluding complete food groups for a period of time, that's when you're looking at both short-term health and long-term health and wellness issues, and that's what we want to avoid, and that's where we tend to suggest that we intervene. So,
do you have time for one more? A few minutes? All right. How do I pay for feeding therapy? Often, let me take that back. Maybe not often. Sometimes insurance will cover feeding therapy as part of ABA. Otherwise, here at the Johnson Center, we can help you get funding for feeding therapy, or help you find grant or work with you to find some way to get that service if you need it and your insurance is not going to cover it. Do you know anything more about it, Kelly?
in terms of the grant application program, or
In terms of paying for it?
so we tend to have on the front end when we start looking at insurance reimbursement, that's really the first stop. We've also worked with several families who get state or local funding reimbursement as a component of support that they're receiving from grants or class support or other programs that are set up to support families of children with autism. We have lots of families. We have several families who've set up fundraisers to cover the cost. They've done garage sales, bake sales, various things to raise those funds. And as Amanda mentioned, we're here. We are very helpful through our family care department in locating grants that specifically are interested in funding feeding programs. So.
Okay.
I think that's about all we have time for today. Thank you so much for your participation. And I think our next webinar is in a few weeks. Thanks so much.
And if you need that certificate of attendance, you'll get an email shortly for a quiz.